Good afternoon, everyone. Welcome to CMI's webinar today, Protecting Our Kids After Quarantine. Today's webinar is brought to you by CMI, Centre Medical International. CMI is a premier outpatient clinic located in the heart of BGC. With over 150 specialists on our roster, CMI continues to be here for you for your medical needs. CMI is a freestanding clinic that offers specialist consultations by phone, by video, or in person, diagnostic procedures, and preventive treatments such as vaccinations and checkups. At CMI, there are no crowds, no queues, no hassle. CMI is the safe clinic for you and all those who are dear to you. Hi, my name is Joseph Romero, CMI President and your moderator for today. Thank you for joining us this webinar. As I mentioned, protecting our kids after quarantine. After the quarantine period, we say hello to those who are joining us by Zoom, and we also say hello to those who are joining us through Facebook as we do a live streaming on our Facebook page. I am personally excited and honored to have our speakers today. Our speakers today are Dr. Benjamin Ko, who is CMI specialist in pediatrics, clinical pharmacology, and infectious diseases, and Dr. Olivia Reyes, CMI specialist in emergency pediatrics, and I'll say more about them in a bit. The context for today's webinar is basically our role as parents, guardians, or close relative to kids. Perhaps there's no role that is more important or more crucial. And at this time, our kids are looking to us, maybe directly or indirectly, for direction and help in making sense of what is going on and what is even going on inside themselves as they are cooped up like with the rest of the family. CMI wants to make sure that we're able to provide you with medical support however we can, including through webinars like this. We want to support each other and as much as possible devote resources for you as we continue with our mission of providing premier patient experiences. Before we proceed, just a few reminders. So we've started exactly at 5 and we've muted your audio, your microphones and your video capabilities. And very important, please use the Q&A chat box at the center of your screen at the bottom. Already we have a couple of questions typed in already and we'll get to those in a bit. And if you have not already done so, please provide us with your full name to help us identify you properly so that we can get in touch with you if you have questions or any other needs that we could help you with. And now, as I said, I'm excited and it is my distinct pleasure to introduce you to our first speaker, Dr. Benjamin Ko. Dr. Ko is a very, very busy man. He's jetting from one webinar to another, as is the case today. Dr. Ko is a practicing board-certified pediatrician and associate member of the Pediatric Infectious Disease Society of the Philippines. He finished his medical degree at the University of Santo Tomas and did his residency training there as well. He did his fellowship training in clinical and molecular pharmacology at the Boston University in Massachusetts. He was the former director for Center for Drug Regulation and Research of the Food and Drug Administration of the DOH. He is a fellow of the Philippine Pediatric Society and Philippine Society of Experimental and Clinical Pharmacology. He is also a member of the American Society of Clinical Pharmacology and Therapeutics. Dr. Ko is currently a faculty member for the course diploma in regulatory science and management of the Ateneo and is an author of 46 local and international publications and editor of 9 textbooks and handbooks in pediatrics, pharmacology, and pharmaceutics. It is always a pleasure having Dr. Ko. Ladies and gentlemen, please welcome Dr. Benjamin Ko.
Hello, good afternoon, everyone.
Hi, Dr. Ko.
Yeah, let me get my slides ready. This is my third webinar for the day. So let me see. Okay. Can everybody see the screen?
Yep, we can.
Yeah, all right. So my topic is on protecting our kids after quarantine. And basically, I will provide you some guidances on providing pediatric well care during COVID-19. I downloaded part of the recommendation of the American Academy of Pediatrics, which is the most recent recommendation, particularly for pediatric well care during COVID-19. There are a few changes and a few modifications for the local setting, which I incorporated as well, particularly for when we talk about immunization and vaccines, which is part of the Pediatric Infectious Disease Society of the Philippines and the Philippine Pediatric Society recommendation, considering that we are all residing in the Philippines. Okay, so let's start. So since the onset of the pandemic, there has been a significant drop actually in well child visits and in delayed immunization. And these delays in child visits, referrals, anticipatory guidance cannot assure us of the optimal health we can provide to our kids. So there are additional elements that require in-person visits, and there are concerns that exist that delay immunizations and can result in secondary outbreaks with vaccine preventable diseases. And for you, all of you who are in the audience that know the problems we've had in the Philippines last year from several outbreaks of dengue, followed by measles, and then this year, the late part of the year, we had polio as an outbreak, and we've not even resolved the polio virus outbreak when coronavirus stepped into the picture. So it's one outbreak after another outbreak with many of the vaccine preventable infectious diseases, except for COVID-19. So as primary care pediatricians, we are prepared to ensure all newborns, infants, children, and adolescents should be up to date on not only immunization, but comprehensive well care, child care, which is inclusive of appropriate screening, complete physical examination, lab exams, and vaccines. And I borrowed this from my friend Anna. Um, it's in Tagalog, so for those that don't read Tagalog, I'll explain it to you. We shouldn't forget that we need to either go to the local health center or to your pediatrician for the vaccines we have forgotten, because while we have COVID circulating around, the other microorganisms are not sleeping. So they're still there in the environment, and we must make sure, and we should be made aware that there is a protection against these other infectious diseases, which we call vaccine preventable diseases. They're invisible, invincible, and when we sleep, they rise. We are closing in on the flu season, and June, the rainy months, is actually the flu season. And it's not only the rainy months here in the Philippines does not only bring flu, but it also brings dengue and measles as other infectious diseases, which are actually what I call the perfect storm. Because together with an ongoing COVID-19 crisis, pandemically and locally, it's not something that you would like to see, because the presentation of these diseases are very similar to coronavirus, SARS-CoV-2. So while child care visits should occur in person as much as possible and within the child's medical home, where continuity of care may be established and maintained. And for those that are, well, in my private practice, and when I restarted my clinic, I've always told, I've given the webinar for restarting clinics. I've always told people that we need to separate well child from sick children visits. So at the hospitals, what we do now is that all well child visits are scheduled in the morning, and all sick children are seen in the afternoon. So it gives us time to actually clean and disinfect the various rooms and put the children at lowest risk first, and then those at higher risk last. Pediatricians should identify children who have missed well-child visits and or recommended immunizations, and we should try to contact them to schedule them in-person appointments, and this is across the spectrum. But the preference, particularly during a lockdown period, the preferential age of those that we should be seeing in the clinic are those that are for primary immunization, because those for boosters and catch-up immunizations can be rescheduled. It's like having an elective surgical procedure. So pediatricians should actually work with families to bring children up to date as quickly as possible. And an electronic health record system can be able to support any catch-up immunization. We should inform families about the strategies already implemented in primary care medical home offices to assure safety. And these examples, these strategies can include scheduling dwell visits, sick visits at different times of the day, as I mentioned, separating patients spatially by placing patients with sick visits in different areas of the primary care clinic. And I think that's something that CMI should look at. How do you separate now, and where do you put patients who you see as well versus patients who you intend to see in the clinic as sick? So what happens if I can't see the patient? Well, in today's AI and digital technology, telehealth and telephone care service is an important tool to connect with patients and families. I personally do telehealth. So I am on two different platforms, one for the hospital, for Asian Hospital, where they have a telehealth platform, and the other one is a personal platform as well. And majority of pediatric illnesses can be managed actually online. 95% of infections are viral etiology. They are self-limited, and patients will eventually get better. What we need to do is we are able to see them even through these means. And as a matter of fact, by doing so, we are able to triage them and see whether they should be seen in the hospital eventually. So every clinic should consider launching a telehealth visit for their families. Now, vaccine preventable diseases at the time of COVID-19, these are current recommendations of the Philippine Pediatric Society and the Infectious Disease Society of the Philippines. So aside from routine measures, we strongly recommend prioritizing completion of primary immunization series and the administration of vaccines against the epidemic-prone diseases, measles, polio, diphtheria, flu, pneumococcal, and rotavirus vaccines are highly recommended. And we specifically tell now the doctors that you try to make sure that you have an appointment-only basis. Many of the clinics actually, except like CMI that does by appointment only, don't do that. So patients come in, first come, first serve, and that results in crowding, and there is a loss of social distancing. But if you're able to space your patients at least 20 to 30 minutes apart, then that gives you a good time to make sure that you disinfect the clinic after seeing each and every patient. But since you'll be seeing well patients, then it will be minimal disinfection. And during consultation, we should allot time to emphasize the importance of keeping the child's vaccine up to date, reinforcing the importance of hygiene, cough etiquettes, and physical distancing. Those that should be given at birth should be given at birth before patients are discharged. There are special circumstances such as exposure to rabies or tetanus, and you cannot wait and you cannot say, well, we'll do the rabies vaccine or the tetanus vaccine after the lockdown, or perhaps a week from today, and we can just clean the wound. No. If the patients are at high risk for rabies or they are at high risk for tetanus, then efforts must be made to avoid delay and you should provide appropriate vaccine following routine recommended schedule. Patients, well, doctors who take part in the epidemic control, because we see some of the doctors who do emergency room um, duties, it is best that they should not participate in immunization activities during the ongoing pandemic. And the reason for that is that it is possible that some of them may come down with the infection or may be asymptomatic and become eventual transmitters to those that see well babies. And this is the catch-up immunization schedule of the Pediatric Infectious Disease Society of the Philippines and the Philippine Pediatric Society. So for children 4 months to 6 years old, for those that have skipped the last 2 months, we just walk through them and make sure that whatever appropriate immunization for age should be administered, we administered. As a matter of fact, I've recommended now that we follow the American Academy of Pediatrics to give DTP, polio, Hib, rotavirus, and pneumococcal vaccine at 2, 4, and 6 months, or at 3, 5, and 7 months, so that they are not delayed in their immunization. You see the same schedule for polio, rotavirus, and the pneumococcal conjugate vaccine, which can all be given together at the same time. And there is, of course, for children aged 7 years old and above, there is a catch-up immunization schedule, particularly for DTaP, which can be given as early as 7 years old, and you don't need to wait for 10 years old before you give the Tdap or the DTaP to your patients. Japanese encephalitis, meningococcal vaccines, and HPV are actually still recommended in spite of the enhanced community quarantine. So we need to get children and teens outside while social distancing as well. Schools are closed. I would advise that we close it for the rest of the school year. I don't think this is something that's going to go away soon. When classes open, particularly in the public schools, this will pose problems. We try to schedule your family while everyone's home. Ideally, this should include some outdoor time. And don't forget to teach the kids safe distancing from others. So we try to explore nature while social distancing. And there's nature around us. We have a yard, we have a tabletop garden. So we can imagine that we virtually are part of nature. Bring out the baby. I mean, I know it's kind of difficult, but if you have an open space, then infants and toddlers actually, when in public spaces, are safest in a carrier or stroller. I think we're going into GCQ, which means that we must be able to, well, the kids can't still go out, so can't the elderly. But as much as possible, if you can bring them out, take a walk around the streets. If your villages and your gated villages will allow it, then it's important that we bring them out. Vitamin D from the sun is always a happy vitamin. If they cannot be kept in place when in public spaces, do not bring them with you. Okay? Do not attempt to do that. But they're safe in a carrier or stroller, and children less than 2 years old should not be wearing a mask because it's dangerous for them. We challenge older children and teens, challenge in the age of digital tools, and we challenge them to participate in other activities. Remember, we must take advantage of the healing power of nature. But at the same time, we must teach our children to stay at least 6 feet away from others outside our family. Teach them hygiene, wash their hands with soap and water, hand sanitizers before, once you return from an adventure, and getting outdoors and moving our bodies is actually good for everyone. For parents in a pandemic, parenting in a pandemic is kind of difficult, and here are some tips to keep the calm at home. Obviously, there will always be fear and uncertainty, and the kids don't know why they're being holed up, particularly the small ones. We need to explain to them, and their brains will always absorb everything we tell them. So they'll be able to absorb the fact that we're able to teach them and make them understand why the virus needs to slow down. And while it is tough for families to keep a sense of calm, it is important to keep children feeling safe and keeping healthy routines, managing their behavior, and building resilience. And we can address the children's fears by answering questions about the pandemic simply and honestly. It's not okay to hear frightening news, but that's all we hear. And sometimes they ask questions. It's all right to answer them. And it's okay to say people are getting sick, but if they hand wash, they stay at home, it will keep the family stay healthy. We should recognize our children's feelings and we should say it calmly. And most difficult is to work with teens through the issues because I know it's disappointing for them not to be able to hang out with their friends. But a lot of the kids are learning to hang out on social media and through Zoom or Viber or whatever um, whatever device there is available. Keeping in touch with loved ones, modeling how to manage feelings, telling your children before you leave for house or the house for work or essential errands that you have to tell them that you're just going out, going to get some goods. How long will I be gone? When will I return? What would you like me to buy for you? And that you're taking steps to stay safe. That's why I'm the only one that has to step out of the house. And you're not coming to the supermarket with me. Look forward and offer extra hugs. Say, I love you a little more often. We need to keep healthy routines, structuring the day with the usual routines thrown off, especially for new daily schedules. Wake up routines, lunch, chores, exercise. It's getting to be redundant, but sometimes we can make things fun, and it's a matter of being able to be innovative during these times of crisis. And a word about bedtimes. Children often have trouble with bedtime during any stressful period, especially during this period wherein they sleep more often during the day and then during the night they're more awake, so you don't know what to do with them. You try to keep a normal nighttime routine such as book, brush, bed for younger children. Put a family picture by their bed for extra love until morning. Bedtimes can shift some for older children and teens, but it's a good idea to keep it in a reasonable range. You don't allow them to just watch Netflix forever and look at all of the K novellas until they fall asleep. Too little sleep makes it more challenging to learn and to deal with emotions. And remember to turn off their cell phones and other mobile devices at least an hour before they go to bed. We need to use positive discipline, redirecting bad behavior, creating plays, directing attention to reinforce good behaviors and discourage others is a powerful tool. We use rewards and privileges to reinforce these good behaviors. Know when not to respond and use timeouts. The discipline tool works best by warning children that they'll get a timeout if they don't stop. Of course, they'll always say, there's nothing to do in the house anyway, so give me a timeout. But remind them that what they did wrong in as few words and with as little emotion as possible, and then remove them from the situation from a preset length of time. Then there's also a special time in, even with everyone home together 24/7. Try to set aside some special time with each child. And you choose the time, let your child choose the activity, and 10 to 20 minutes of your undivided attention will mean a lot to your child. Keep the cell phones off or on silent so you don't get distracted. Because if you're too, your children are just mimic what we do. If you keep touching your mobile phone every now and then to have to answer something while you're spending time with them, they're going to think that, well, if it's okay for you, then it's okay for me. We need to take care of ourselves and to take a deep breath because we need to make sure that in addition to reaching out to others for help, um, parents will feel overwhelmed, especially stressed, trying to take just a few seconds to ask themselves, does the problem represent an immediate danger? How will I feel about this problem tomorrow? And each of us will always ask the question if this situation is permanent or not. With that, I end my talk, and I'd like to remind everyone that even the Centers for Disease in the US have noted that fewer children have received vaccines that have been during the COVID-19 pandemic, and we need to avoid outbreaks of vaccine preventable diseases by keeping our children protected. So schedule your next vaccination and well child visits immediately. Thank you.
Thank you, Dr. Ko. It's always very educational listening to you. We'll get to the questions that have popped up while you were giving your talk. But for now, ladies and gentlemen, please allow me to introduce our next speaker, Dr. Olivia Reyes. Everyone in CMI calls her Dr. QPI. Doc QPI is a practicing pediatric emergency medicine specialist here at CMI. She is also currently a consultant of the Department of Pediatrics at PGH. She finished her medical degree at UP and underwent clinical clerkship at the University of the Philippines also, and at Weill Cornell School of Medicine in Manhattan. She also did her observership for neonatology at the Radboud University Medical Center in Nijmegen, Netherlands. Dr. Pai is a diplomat of the Philippine Pediatric Society. She is also a certified instructor for pediatric advanced life support and in advanced trauma life support. Ladies and gentlemen, Dr. Pai Reyes. Over to you, Doc.
Hello, everyone, and thank you, John, for that kind introduction. Now, from our well child care services, I would now venture on to how pediatric urgent care provides another avenue of healthcare delivery during COVID-19. So before I actually start discussing about pediatric care, it's important to sort of jump off from the pediatric healthcare services that are available in the Philippine private healthcare setting. So basically, for the private services, we're divided into well child services and sick child services. Well child care, as previously mentioned by Dr. Ko earlier, is centered on child services that are directed towards monitoring, maintenance, and preventive child care. So this is with growth and monitoring, vaccinations, screening based on age-based recommendations, anticipatory guidance, and injury prevention advice for the parent and the child. Sick child care, on the other hand, is more directed towards addressing a specific symptom or complaint, or possibly an acute or worsening condition that's been chronic or that's been there with the child, and has differing levels of acuity from mild, moderate, and severe. Modes of healthcare delivery within the Philippine setting, from acute to the non-acute or the simple illnesses, have a wide range of delivery services. So for children who are very sick, they are the ones that avail of the emergency services within the emergency department, and this is usually hospital-based. And usually we cater to the high acuity cases with life-threatening or limb-threatening conditions. Sometimes low acuity cases also come in because of the convenience and time constraints, but in general, this is not advised. And the length of stay is very short, within 4 to 6 hours. So we already need to decide if the child needs to be admitted or can be sent home. So if the child needs to be admitted, they then transition on to inpatient services, wherein definitive care for the diagnosis of the child or the condition is provided. So this includes IV hydration, and of course, the provision of IV antibiotics in the setting of infection. Surgical interventions are also provided by inpatient services. Outpatient services, on the other hand, center on well child activities, as I mentioned earlier, sick child services as well, mild illnesses or those with stable chronic conditions, and can occur within the setting of the clinic, via telemedicine as well, and the pediatric urgent care service. So in general, the clinic has different locations, can be hospital-based, retail-based, or freestanding facilities like ours, which is located in a commercial building, or home clinics as well. Telemedicine, on the other hand, is an emerging avenue of care. Most doctors are transitioning to this, and this is wherein they use electronic communication in order to treat the problem of the child or improve the healthcare status of the child. So this is usually remote and is very dependent on accurate and comprehensive history because of the limitations of physical examination and as well as the time constraint. So basically you don't have the field component of a pediatric consult. It's also sometimes challenging because follow-up sometimes does not always occur. And in general, if you're talking about non-experienced providers, non-experienced childcare providers, this is not recommended for children who are less than 2 years old. Pediatric urgent care services, on the other hand, is focused on the acute assessment and management of mild or moderately ill or even injured children. So the range of pediatric urgent care services sort of overlaps from the clinic with telemedicine capability and the emergency department. So it's on-demand service at a reasonable cost. And the setting can be hospital-based, but for our pediatric urgent care service, we are a freestanding facility. And staff is also trained very well to determine and initiate the transfer to a higher level of care. In particular, CMI offers the following services. So we have simple preliminary laboratory examinations like a complete blood count, glucose, urinalysis, and also screening for dengue. Imaging is also provided by doing our x-rays. Ultrasound is also provided, point of care ultrasound based on the skill of the urgent care physician available, and also the radiologists also go on call within our clinic. We also have ECG and EEG, and we're able to refer to a wide range of subspecialty practitioners who are very well trained in their own specific field. Treatment as well and observation is one thing that I would like to stress that additional benefit that pediatric urgent care offers. So we're able to start oral medications. We have our in-house pharmacy, and we also have the provision for IV medications, or be able to start and see if the child responds with IV fluid administration. Observation is also available because we do have separate rooms which can function as short stay beds for a maximum of 4 hours with, again, smooth coordination and transition for patients needing a higher level of care. So this is just a bird's eye view of the different modes of healthcare delivery. And I just highlighted what makes each unique. So emergency services for the sick child, resuscitation, inpatient services, this is definitive care for the serious illnesses. And the clinic would provide the well child care, as I mentioned earlier, the routine child care. Telemedicine in particular is very good because it's no contact care. And actually also effective as a triage in order to direct patients now in terms of where to go so they can access services. Urgent care sort of loops everything all into one because that's just the way CMI and even urgent care services abroad have patterned themselves. So these are advantages and disadvantages. Just to reiterate, maybe the most important disadvantage of telemedicine, again, because of the lack of information that you can get, will be your delay in treatment. So remember, telemedicine is not appropriate for moderate to severe illnesses. So let's talk about COVID-19 and child healthcare services. What changed during the enhanced community quarantine? So these are the clinical manifestations of COVID-19. You have the systemic symptoms such as fever, body ache, loss of appetite, especially the respiratory symptoms, cough, colds, the sore throat. These kinds of complaints, patients presenting with these complaints will invariably always be directed to the emergency room. There's a question about asymptomatic carriers. Right now, we can't really determine who has it and who does not. But in general, if you don't have systemic symptoms or the respiratory symptoms, then you can go to the clinic. COVID-19 transmission, it's highly transmissible via contact and droplet precautions. I would like to emphasize that this is not airborne, except in high-risk settings such as the emergency room or the ICU, wherein transmission can occur via aerosolized procedures. So what happened during the initial phase of ECQ? There was a halt in the well child services. So as was mentioned earlier, vaccinations came to a stop. Well child services such as screening also came to a stop, which puts us in a bit of a conundrum now. There was emergence of telemedicine, and of course the telemedicine was able to assist in terms of triaging patients towards seeking help at the point wherein they need emergency care. Mid to late phase ECQ child healthcare services, we saw more freestanding clinics open with the provision of care on a case-to-case basis with better risk assessment profile of which patients can actually go to the clinic and with safety precautions such as a pre-book and pre-screening strategies employed. Again, COVID symptoms are triaged to the emergency department. COVID symptoms and non-COVID symptoms, this is just a summary slide, but again, telemedicine played a crucial role in facilitating healthcare during ECQ. So what was the consequence? There were fewer sick children, but actually because of the delay in care and uncertainty of care, there was actually more severe illness in the children that come to the ER. Now, let's see what will happen during ECQ, MCQ rather, during modified community quarantine. What will change? So basically, those with COVID symptoms right now, the recommendations remain so we can limit transmission to access care through telemedicine and via the emergency department. Non-COVID symptoms are advised, consults are advised pre-screening with scheduled appointments. So basically a walk-in appointment is not recommended at this time. If you need immediate care, the emergency room will be the only one equipped at this particular time, wherein the clinics do not really have the processes yet to accommodate you. Primary care provider clinics are slowly doing dry runs and opening up, especially the hospital-based ones. And of course, CMI, urgent care, as a freestanding healthcare facility will just function as is. So from the recommendations that was mentioned by Dr. Ko earlier, with the resumption of well child services, these are just some of the points that they centered on in terms of how healthcare providers can ensure or minimize risk in terms of contracting COVID-19 within their healthcare facility. So I'd like to emphasize, number one is hand hygiene. Really, there's really no substitute for clean hands. And for the masks, just a clarification, those above 2 years of age are required to wear masks. If they're less than 2, you don't need to put a mask on them because it's actually very hard for them to breathe. And if the adults or the primary carriers of COVID are on masks anyway, then that's actually protecting them as well. Of course, services with patient triage and segregation, just in case suddenly you detect someone who's sick, should be provided. And of course, ongoing patient and family education, even at a distance, by infographics or videos sent to patients, will always be of help. So to wrap things up, maybe just to give you a little picture of how we functioned during the time of COVID. There was very early recognition of the need to modify our practices. So actually January 2020, we were already reviewing our facility capabilities, such as the negative pressure airflow, the HEPA filters, and UV cleaning at night. So we do not do UV cleaning when people are within the facility, because this is actually quite dangerous. But our pre-existing structural design, which was actually quite expensive, but it really benefited us in this time, because we're able to have increased airflow changes, especially when we don't have windows that open up into the environment. And of course, because we have competent and dedicated pediatric staff, both nursing and the pediatric care practitioners, the board certified pediatricians, they are experienced providers with competitive training. So we were able to actually pre-screen patients and effectively triage them to appropriate care. So just to wrap things up, our current practice has adhered to standards that are put forth by expert recommendations made for outpatient facilities. And as our commitment, CMI Pediatric Urgent Care will always be committed to delivering safe and high quality care within our scope of practice. Thank you very much. And I guess we can turn over to our questions, which may be something very useful to everyone right now.
Thank you, Docupai. We've had, just for the information of Dr. Ko and Dr. Reyes, even as of yesterday, we've been getting emailed questions already about COVID and life after COVID for kids and protecting them after quarantine. One of the questions we got is actually related to the Kawasaki disease, Dr. Ko. A mother was asking, her son was diagnosed with the disease, Kawasaki disease, when he was 4 years old, which was 2 years ago. Does that mean this kid is more susceptible now to COVID? Or if he, the follow-up question is, if he gets COVID, can he possibly get Kawasaki again, Dr. Ko?
We all know that one of the causes, we all know that one of the common causes, or one of the infectious disease causes of Kawasaki is actually coronavirus. So, we know that from the literature, we know that from some of the viral studies and the publications already. So, whether he is more or she is more susceptible to developing another episode of Kawasaki, that has never happened. I've never seen a repeat Kawasaki in my lifetime. So we've always said that once you've had one, then you've had one. Okay. Now, as to whether it is one that will trigger a second wave for Kawasaki, we really don't have information on that. But what we do know is one Kawasaki episode in your lifetime is it. Whether it is from coronavirus or it is due to any other enterovirus, any viral infection that may have triggered Kawasaki, because Kawasaki is an immunologic disease. Okay, it is one that is classified under immunologic rheumatologic disorders. So this trigger mechanism on the whole immune system of the patient has created that particular problem in the inflammatory process of the patient that comes down with KD. Like I said, I don't know if it will recur. or one will be more susceptible? I don't think so. My answer there is I don't think so. And if it does, then that will be another one for the books.
Okay. Thank you, Dr. Go. And then there's some questions that you've answered already over the Q&A chat. Dr. Ko, before I get to my question, the burning question of the day is your comment on rapid testing, I guess in general and for kids in particular.
Do I recommend? No, I don't.
Okay.
And neither does the Pediatric Infectious Disease Society, neither does the Philippine Society of Microbiology. And we feel that it's not, we feel that it's okay as a screening, but it may give you a false sense of security. Well, especially the fact that the antibodies begin to form only after the second to the third week. Okay? And they stay a little high after the second to the third week. There are two types of antibodies that are formed. One is IgG, the other one is IgM. IgM meaning that you have had a recent infection, and IgG meaning you have had a past infection. Now, the question there is, what happens if your patient gets tested and tests negative, but he may have been exposed to someone and is incubating? So that's in the first 2 weeks. So the probability that you will not pick him up is very high. You get the point?
Yes.
Because the IgG will, the IgM will not pick up until almost about the during the period of the second week. So that's why it keeps going back to the gold standard, RT-PCR.
Which is
because
the swab
RT-PCR,
test.
yes, can be detected once there is an onset of symptom. And that's the precaution, because even RT-PCR is not perfect. The RT-PCR has a 1/3 chance of being false negative. So, and it has a higher false negative rate among patients who are asymptomatic. Because it is presumed that patients who are symptomatic may have higher viral loads. That's why they have the symptoms. And that's the reason why, in order to conserve the RT-PCR, because they're very limited kits, we wait for patients to have symptoms or who have exposure to patients who are positive, of immediate exposure and close contact with patients who are positive. That's the only time we do contact tracing using RT-PCR.
Thank you, Dr. Ko. Doc, we move from the hospital, the clinic to the household. If, say, a parent or grandparent that the child lives with contracts COVID and recovers, how many days or how long before that child can interact again with the adult? Is there a rule of thumb or a safe buffer or margin?
Well, for now, we actually recommend whether it's a grandparent or a parent, any COVID-19 confirmed case, to be able to interact with everybody after 2 negative swabs. So right now, that's
okay.
However, we have been seeing a lot of patients that have positive swabs even more than the appointed 14 to 21 days. So what do we do there, right? So if and when that still occurs, we still recommend self-quarantine. That's the safest because again, when you're talking about the swab, we do it through the nose and through the mouth. And to be able to detect the virus there should be viral load in the nose and the mouth. And that means it's still transmissible. There's still a possibility, even if it's long after the 14 days. So sometimes, yes, we can send them home, but they need to be self-quarantined. And the sending home part is really just because we don't have enough quarantine facilities as of the moment.
Okay. Doc, just to follow up, because one of the questions we also got was some households have or some families have household help that live outside of their residence. So they live in other probably cities or areas of the city, and so they go back and forth the residents, the family residents. Um, what safety precautions should, first of all, is that a good idea? Second, what safety precautions should be taken by everyone involved?
Well, first and foremost, any kind of movement during this time, if there's movement from one place to another, it always increases exposure. If someone lives outside the home and goes to work for you, that means they're traveling using
Whatever
mass
means, yeah.
transportation. Yes, they have to be exposed outside, not unless they walk all the way. The distance will be in question, but it's generally not a good idea to move. You can't control the environment where they live as well. So outside of your home, sometimes they live in close proximity to each other, so that can also be a problem. You can't control the transmission there, and you can't detect it if they can be asymptomatic carriers. However, if this situation cannot be avoided, again, clean hands. That's what I always say. Clean your hands. Hand hygiene is the best. And always require them to wear a mask if they are doing work within close proximity, 1 to 2 meters. They need to be wearing some kind of barrier when they're doing work in the home. And that actually can mitigate the risk.
Okay, thanks, Doc. And then a lot of mommies are asking questions. Can kids engage in outdoor sports? So I guess, can they go swimming? Can they go running around? Dr. Benji did mention earlier
If
that,
you have your own swimming pool, why not?
okay, but if it's public or it's part of your condo,
No,
no.
how do you do? No. If you have your own pool in your backyard, go ahead. Why not?
Okay.
Right?
Related to that, and it's probably for the both of you or whoever wants to take it, um, how do we boost the immune system of kids? You mentioned sleep, but is there, you know, a prioritization order, or is there a prescribed process to it?
Care for children is very holistic. So I think you can't isolate one from the other. It's really a combination of balanced diet, physical activity, also emotional and social interaction, emotional support. These all come into play when you're talking about keeping a child healthy. Even depression can actually parang lower your immune system. So
Mhm.
maybe to the best of our ability, just to sort of give a balanced attention to all these things. But in particular, I think good rest, adequate rest, and nutrition should be at the top of the list.
Okay, thank you. Just to follow up, there's a question here in the Q&A chat box. Aside from the usual multivitamins that are mostly OTC, would you recommend any specific vitamins to be added to their daily intake? So those would be zinc and yeah, zinc and I don't know, magnesium or whatever. Is that recommended for kids?
I've always believed that multivitamins will always stimulate the growth of the pharmaceutical company.
Okay.
So
I
if you
thought
believe in that, if you believe in that crap, I'm sorry. What I'm saying is, you see, if you and Olivia was right. You feed well. Q was right. No, you feed, sleep well, balanced diet. These are important. I mean, you get all the essential vitamins with good food that you serve. This is the time that it's a good time that we're in lockdown. There are there are very few junk food running around.
That is true.
Mommy
yes.
and daddy gets to learn how to cook, and you know it's giving your kids better food and a lot of rest. They're less stressed from schoolwork. They get a lot of drink. And it's a very good time to to bond with your family. Don't make the pharmaceutical companies richer than they are already. They're very rich already. Water-soluble vitamins, when you take it in excess amount gets excreted in urine.
Mhm.
So you just find it in the urine. No matter how much you give, it will just come out in the urine. So thank you for making your toilet bowl smell.
Well,
Thank you.
just wanted to add a caveat to that lang. Kasi, because I'm also exposed to take care of very sick children. When they have chronic illnesses that predispose them to not being able to get the right nutrition, then that's the time wherein we actually think about supplementing. So we're talking about children that have gastrointestinal illnesses, that have difficulty in absorption, or cannot really take the normal diet that a healthy child can. Then there may be a role. And I say may because it's not all the time. So if your child is healthy, just make sure to ask your pediatrician first if they need it or not. So this can also come into play when you're doing growth monitoring. So when you're plotting the child and maybe they're not growing well, then maybe you need to investigate. And as a stopgap, sometimes you can try to start the vitamins in order to try to stimulate the growth a little bit. And this is for nutrition deficient kids, okay?
Yes.
Nutrition deficient kids.
Yes, so, not for the healthy child population.
Dr. Koa, Dr. Cupay, we have around 3 to 4 minutes left, and there's around a couple more I want to get through. Are you okay to extend just a little bit beyond the 6 p.m.? Okay. And then to our audience, we've taken note of all of the questions, and we will, if you've provided your full name, we will get back to you. Because I have a 17-year-old son, and it frustrates me that he's dieting. He's like he doesn't eat rice, and is it? And it's always so I save my peevishness for a lower stakes crisis. So I try to engage him in conversation. Is that okay for 17-year-old, 18-year-old kids to go on a diet at this time? Because of course they're worried about their weight, but I am of a different mindset, but I'm not sure if I'm correct.
Q, you want to answer that?
Well, okay. So when we talk about dieting, the premise has to be established. The child in the danger of obesity because it's also a disease. So are they in that state? And the next question would be if they're obese, then what is the right strategy? For in general, for kids, diet has to be planned and has to be gradual. We cannot put them on the crash diets or the IF strategy.
Right.
Are applicable to adults because the metabolism is different. The adolescents are kind of tricky because they look like adults. They're taller and they're bigger. But then we forget that the physiology is not an adult yet. Not quite the adult level yet. So it has to be catered case-to-case basis. A pediatrician can guide you for that. And for some cases, I actually refer them to our nutritionist in CMI because I need a little bit more of help in determining what is the right strategy for this child. Psychological factors can also play a role. So it's not a cut and dried answer. But to get back to your question, Rice, as long as he's not nutrition deficient,
okay,
or he's not unhealthy, he doesn't have obesity, he's not on the lean side, okay lang. I think it's okay because if he's getting the nutrients anyway. And if you look at the food plate, the pattern now is that, you use the hand. So vegetables, the entire hand, entire palm. Meat will be, this area, and then rice will just be this one. So little rice is okay.
Right. So I asked that for myself and a couple of our attendees actually.
Yeah, because you will have to ask your son why he's on a diet. That was actually going to be my answer.
Okay.
You will need to ask him why he is going on a diet, because he might want to look good for his girlfriend, or he might want to look thin because, he feels that you're fat and everybody else in the family is fat, or that he's getting bullied, that people are picking on him. That's why he wants to go on a diet, and so on and so forth. He's 17. 17-year-olds don't do that spontaneously unless somebody is prodding them to do it, or they may have a personal reason for it. So I think, to me, you need to talk to your son. And
Context.
if I was saying that while that's the overall arcing goal, that you have to take a lot of things into consideration, I always go back to the parents and ask them, and I tell them to talk to their kid. Why are you on a diet? They'll tell you why.
Okay, thanks, Doc. And then again, so many great questions. Sorry. One is, and I think this goes for adults as well. A lot of people have increased their screen time already, and kids are more vulnerable of damage to eyesight if that's proven. How much should we then continue to limit screen time? What else can we do to protect their eyesight during this time? Doc, you?
I think this is a time wherein there's also a more liberal approach to screen time. I would usually recommend less than 2 hours for children before COVID. But now it's such a challenge to be able to keep them occupied during the day, because their work equals school. School is not there, daycare is not there, play dates are not there. So then screen time becomes a little bit, of course, for the working parents. The parents don't stop working, they're on home work. Sometimes it can be an effective tool to keep the child busy. However, I think it should still be limited. Maybe in terms of the eyesight, there should be proper lighting and distance, at least a foot, like 12 inches, because if and when the eyes, there's eye strain, then that will actually lead to more problems. So limit, but not as limited as 2 hours, maybe 6 to 8.
2.5.
There's school. Because some of my patients also have their homework on the iPad.
Right, that is true. Yes.
Actually, the recommendation is 2 hours of non-academic related screen time.
Got it. Thank you. Dr. Ko, did you have anything to add?
No.
Okay.
Yeah. Well, the parents are also equally stuck to the Netflix, iFlix, and so it's like I said. Kids will only follow what you do. So if you tell them that they're not supposed to be watching too much screen time, you should do it yourself as well, because they just copy. They'll just mimic. Why are you watching that? Why can't I be watching this? I want to be watching that too, so on and so forth. And
our Dr. Adele Samson commented, actually, for every 4 hours of screen time, which is a lot for me, 1 hour of rest. I use lots of lubricants and good ambient lighting. Okay. And then just in case, it's probably the last question I'll ask now, given the timer, one or two more. What's the recommended pathway of care now when our child gets sick? Because you mentioned there's no more walk-ins. In hospitals, you have respiratory problems. You're triage to the ER, which is kind of scary. So what's the pathway of care now, slip of the tongue, when a child gets sick?
So triage level wise, for respiratory illnesses, we actually distance telemedicine
Okay.
for illnesses. So that should be an avenue that's available for the patients. Most clinics and most primary care pediatricians have opened telemedicine practices. It's a mild cough, cold, sore throat, mild fever, then there's actually room for that. But when it's prolonged more than 3 days, more severe, you are actually advised to go to the emergency department. We've actually made precautions because I do work in an emergency setting. We've made precautions to separate even the patients in the part of the emergency room that caters for COVID patients. So we have isolated treatment rooms that have closed doors. We classify them, the patients, according to confirmed COVID cases, which have the positive swab results, versus the suspected cases, which have the mild symptoms but not the full-blown COVID presentation, or the probable ones that, yes, they look like COVID, but they don't have the results yet for one reason or another. Emergency departments have been able to separate patients that way because I understand it's scary to go to the COVID area of the ER. So the ER usually, it's divided pa rin between COVID and non-COVID. So most hospitals have done that. But within the COVID area, we've also subdivided these patients according to their case definition. If they're confirmed, they're probable, or they're suspected. So the risk is also minimized. So if you go to the ER, rest assured, most ERs are prepared and really try to segregate patients within the COVID area as well.
Okay. Thanks, Doc.
Let's see, Doc Benji can actually take the floor for OPD services.
Now, well, you're right. No, we just do telemedicine. Like me, I work in a hospital setting, so I separate all my well and sick patients. So all my sick patients, I see them on telehealth. On my well patients, I screen them. I actually send them a letter and I send them a form which they have to fill up, which is a health declaration form, similar to the ones that you use when you come in from another country. It's a checklist and you have to sign it, print, fill, sign, and you must not lie that, you know, just because you wanted to see me, you declared you're all healthy. Then I do a second triage in the clinic. That means we take the temperatures and the secretaries check the patients before I get to see you. But like I said, we only see low-risk patients first. Okay. The high risk, the higher ones, so the ones that are sick, I see them on telehealth. If they are more severe and I feel that on telehealth they should go to see a doctor physically, then I tell them that I will not be able to treat you here and that you must go and see a doctor physically.
Thanks, Doc. I'm going to end with the last question that's going to take us back to our homes. Before that, Dr. Del Samson actually clarified, for every 3 hours of screen time, 1 hour of rest. Maybe because I commented. So going back to the home as our last question, what's the best sanitizer to use at home? I know we advocate clean hands. Would you recommend using UV lights? And also, when we're outside, do we have to use face shields because we have this habit of touching our faces? So just these habits and small things that we might not be so mindful of.
Face shields are okay, but I think the mask is the more useful.
The mask.
Yes, because it's a little bit less uncomfortable. You can't actually hear people when you're in a face shield. It's actually
that is true.
yes. And if you're not undergoing aerosolized procedures, then you don't really need it. I work in the emergency department, so we need the face shield because we need the added barrier, and we also use either a reusable respirator or the N95. That's precautions because there are aerosols. But if you're not in aerosols, as long as you're not touching your hands and you're cleaning your hands and you have a mask, then that's actually enough already to protect you.
Dr. Ko, best sanitizer to use? Your thoughts?
Well, tama naman si Cupay, no? You just wash your hands, keep a face mask on, and the sanitizer that you can use, as long as it is 60 to 90%, 60% and above, alcohol is enough. There are hand gels, there are hand sanitizers, but just make sure you wash your hands. Wash, 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 and wash. Wash, lather. You know, the kids, you don't just wash. You watch them lather it. Bumubula. Yeah. And then you have to teach them how to do it. Sing one whole happy birthday song. Okay? Happy birthday to you. Happy birthday to you. It's not like you just wash and then that's it. No. And then make sure you have a clean environment. We're more cautious about this now. Sadly, we needed an outbreak to make us more cautious that there is nothing better than hygiene to prevent a pandemic. It's a very painful lesson for everyone.
I think that is a good note to end on. Thank you, Dr. Ko. Thank you, Dr. Cupay. This will not be the last webinar we will have based on the number of questions we have gotten. So we'll be in touch. Meanwhile, ladies and gentlemen, thank you so much for joining us. Before I let you go, I just want to let you know that should you wish to set an appointment with Dr. Benji Ko or Dr. Cupay, CMI, these are contact details. We're open Tuesdays to Fridays, 8 to 4 p.m. Follow us or check us out on our social media accounts, and we have this mobile and email for you to be able to reach us. Lastly, we have another webinar tomorrow. We go to the other end of the spectrum, and the webinar tomorrow is called Life After Quarantine, Protecting Our At-Risk Seniors. So it starts a bit earlier, 4 p.m. And what's this? We have Dr. Mark Abad and Dr. Ana Rubio, Krista Rubio, who will be our resource speakers, and tomorrow's webinar will be moderated by Dr. Hazel Zulig. I just got a message to remind everyone that, of course, in CMI, we do teleconsultations as well, both for adult and pediatric patients. I'd like to end there. Thank you very much, Dr. Ko, Dr. Cupay, and all attendees. Thanks very much for your time, and we hope to see you again. Good night.